Welcome, everyone. I'm Kira Curtin, Senior Editor at GenomeWeb, and I'll be your moderator today. The title of today's webinar is Unexplained Epilepsy, Best Practices for Exome Sequencing as a First-Line Testing Option, and is sponsored by GeneDx. Our speakers today are Dr. Isabella Herman, a pediatric neurologist and neurogeneticist at Boys Town National Research Hospital, and Kirsten Kelly, a genetic counselor and medical science liaison at GeneDx. You may type in a question anytime during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar presentation. And if you look to the bottom tray of your window, there are a series of widgets to enhance your webinar experience. And with that, I'll turn it over to Dr. Herman.
Thank you, Kiara. So today's topic is unexplained epilepsy. We'll talk about best practices for exome sequencing as a first-line testing option. Today's objectives are to provide an overview of epilepsy and genetic testing, to discuss the evidence that informed the practice guidelines for genetic testing in patients with unexplained epilepsy, to discuss the clinical and personal utility of genetic testing for patient populations and their families. We will go over a couple of case studies, and then we'll wrap up with considerations for implementing genetic testing into clinical practice using guideline and evidence-based approaches. So epilepsy is one of my clinical focuses in the pediatric neurology and neurogenetics clinic. About 1.2% of the US population has epilepsy. If you want specific numbers, that is around 3.4 million individuals, and of those, 470,000 children are affected by epilepsy. So it's a very common diagnosis. The definition of epilepsy is as follows. Patients who have epilepsy will be diagnosed because they have 2 or more unprovoked seizures. They have 1 unprovoked seizure with the risk of developing additional seizures, or there is a diagnosis of an underlying epilepsy syndrome. So the importance of diagnosing epilepsy is because epilepsy can lead to significant morbidity and mortality. Epilepsy can lead to sudden, unexpected death. So people with epilepsy sometimes pass away suddenly. Epilepsy can lead to premature mortality, both because of SUDEP or other reasons. Patients with epilepsy can suffer other accidents. And then many individuals with epilepsy have other neurodevelopmental comorbidities. These comorbidities include developmental delay, intellectual disability, autism spectrum disorder, attention deficit disorder, or other underlying neuropsychiatric disorders. The clinical assessment and diagnosis of epilepsy has traditionally included medical history taking, blood work, including labs, neuropsychological tests, a neurological examination, an electroencephalogram or EEG, and then imaging studies such as an MRI, a CT of the head, a PET scan, etc. Genetic testing has therefore become increasingly integrated as part of the clinical workup to assist with diagnosis and help guide management for patients. And I hope to show you guys throughout this presentation why genetic testing has become so much more important than it previously was. Genetic testing can make a difference in the patient clinical treatment, outlook, and prognosis. When we define epilepsy or diagnose epilepsy based on explained cases or unexplained cases. Explained cases of epilepsy include about half of all epilepsy cases. These patients usually have an underlying acquired etiology, such as trauma, infection, stroke, structural brain abnormalities, or hypoxic ischemic injury. Unexplained cases of epilepsy constitute about 50% of all patients with epilepsy and are assumed to have an underlying genetic etiology. When we diagnose epilepsy, one of the new terminologies within epilepsy is genetic generalized epilepsy. So unexplained cases of epilepsy are presumed to be genetic, even if we don't have an underlying etiology identified to date. So therefore, a precise genetic diagnosis can lead to more effective treatments and help identify, treat, and/or prevent co-occurring medical conditions for children with epilepsy. When we look at studies that look at the diagnostic yield of genetic testing in epilepsy and looks at outcomes of this testing in epilepsy, we find that up to 80% of the time, patients' genetic test result will have implications for treatment and management. Specifically, patients with a genetic diagnosis can achieve up to 90% seizure reduction in certain situations. And specific genetic diagnoses can mean improved access to resources and clinical trial eligibility. Therefore, genetic diagnoses lead to implementation of precision medicine in epilepsy. So if we look at the history of the genetics of epilepsy, we have come a very long way over the course of 2 to 3 decades. The first gene that was implicated in genetic epilepsy was discovered in 1995. This gene is CHRNA4, and it's the gene for autosomal dominant nocturnal frontal lobe epilepsy. Now, over the course of the last 2 to 3 decades, we have identified over 1,000 different genes that have been implicated with monogenic epilepsies. When we look at gene discovery and identify novel genes causative of epilepsy, most of these genes are usually first identified in the most severe developmental and epileptic encephalopathies. However, over time, with the advancement of clinical knowledge and genetic testing, we have identified that some of these early, very severe genetic changes that cause symptoms such as infantile spasms, developmental and epileptic encephalopathies have been found to have a significant spectrum of disease symptomatology. Now, the reason that this is important is because continued research such as cohort studies, gene discovery, variant databases, and functional testing in this space has been growing exponentially in recent years. And this is critical and crucial to provide continued insights into disease pathogenesis, progression, and treatment. So this graph shows kind of the advancements of gene discovery within genetics, specifically related to epilepsy. If you look at the bottom, I mentioned previously that the first gene for genetic epilepsy was identified in 1997. Between 1997 and 2005, a handful of different genes have been identified, and this era of gene discovery was termed the channelopathy era. So those were very straightforward clinical presentations with very distinguished genetic epilepsies. Between 2005 and 2009, there's a little bit of a halt in gene discovery in what we term the dark ages. And then with the advancement of next generation sequencing and the availability of genetic testing, we have really seen an explosion in gene discovery of genetic epilepsy, specifically starting around 2009 up until currently, 2024. And this manuscript with Ingo Helbig being the principal investigator was published in 2023. So if we, do another analysis to date, we probably see that it's continuing to rise. Now, in the post-genomic era that you can see between 2019 and 2023, we continue to see kind of an advancement or explosion of novel disease gene discovery. But the other advantage of this post-genomic era is that we learn so much more about the clinical presentation of these different genes. We learn about phenotypic variability, incomplete penetrance, which is very, very helpful. And this also allows us to study these patients in very large cohorts, which is important for natural history studies, for clinical trials, precision medicine, with the ultimate goal of developing treatments. So I want to talk about some key facts about the genetics of epilepsy. So when we look at genes that cause epilepsy, we have identified genes over time that can cause generalized seizures. And generalized seizures start from all over the brain at the same time. Focal seizures have also been identified as causes for genetic epilepsy, and focal seizures start from one part of the brain or the other and can sometimes migrate. There's other unclassified epilepsy types, such as infantile spasms, which have also been shown to have an underlying genetic etiology. And examples for that are ARX, SCN1A, tuberous sclerosis, etc. The percentage of patients with a genetic variant is higher for specific epilepsy types, such as infantile spasms, Dravet syndrome, and generalized epilepsy with febrile seizures plus. The inheritance pattern of genetic epilepsies can be variable and can include autosomal dominant, autosomal recessive, or X-linked inheritance. We have also identified that de novo variants can occur frequently, especially with the most severe epilepsy types. As I alluded to earlier, we know that there is a clinical heterogeneity between different genes and different genetic epilepsy types. So we know that pathogenic variants or disease-causing variants in a single gene can be associated with different types of seizures and different types of epilepsy. A good example for that is SCN1A, that can cause very severe developmental and epileptic encephalopathy or can cause febrile seizures. Now, we also know that there is genetic heterogeneity. Conversely, pathogenic variants in different genes can cause the same epilepsy phenotype. Therefore, there's clinical overlap of many genes that has been observed for developmental and epileptic encephalopathies and complex neurodevelopmental disorders. With our advancing knowledge of genes and genetic testing, we now know that molecular testing is so important in order to definitively diagnose a specific cause for a patient's epilepsy. So ultimately, the reason that we want to do genetic testing for epilepsy and other disorders is to see if the additional knowledge has implications in clinical management and outcome. So for epilepsy specifically, many genetic epilepsies are associated with a precision medicine therapy and can be recommended or suggested following specific molecular diagnosis. When we look at data that looks at the outcome of identifying a genetic diagnosis for people with epilepsy, we see that genetic diagnosis can influence treatment in nearly 50% of cases. So this study that was published in JAMA Neurology not too long ago in 2022 is a retrospective cohort study of 400 individuals, and they surveyed healthcare providers and looked at if a genetic etiology determined a change in medical management. And in 21.7% of the patients, a genetic etiology led to changes in management by adding a different medication, initiating a medication. There sometimes is referral to another specialist, depending on what symptoms are associated with this genetic diagnosis. Sometimes there's extraneuronal disease, such as problems with the heart, with the lungs, with the liver that can be seen. And then not too infrequently, almost 12% of the time, a genetic etiology led to the cessation of a medication if that was not the right treatment for the patient. So the figure on the right side kind of quantifies how often there was, a difference in outcome, and this difference in outcome is multifactorial. And when you survey healthcare providers and patient families receiving a diagnosis molecularly or genetically provided a positive outcome in close to 80% of patients who received genetic testing. So therefore, it is very important to consider genetic testing because of the vast implications it can have on a patient's diagnostic journey and ultimate outcome in treatment. So I want to talk a little bit about the clinical and personal utility of genetic testing. So clinically, genetic testing is important because it can lead to changes in treatment and management. It can lead to initiation of precision treatment, avoidance of a treatment that is contraindicated. It can lead to cessation of treatment and/or certain procedures. It can sometimes lead to initiation of palliative care if a rapidly progressive neurodegenerative disorder is identified. Sometimes we get a genetic diagnosis, and this is known to be a syndromic diagnosis that requires surveillance with other body organ systems. Clinically, all of these factors can lead to changes in hospitalization rates, changes in morbidity and mortality. It can provide valuable prognostic information. And then ultimately, it can also help advance research and therapeutic development by leading to potential clinical trial eligibility. Now, personally, for the family and the patient that receives genetic testing, especially in pediatrics, which is my field of interest, it can significantly inform recurrence risk estimation. It leads to genetic counseling with genetic counselors. It leads to reproductive planning. It can also lead to availability of prenatal diagnosis or pre-implantation genetic diagnosis. For example, if a family has a child that is affected with a significant neurodegenerative disorder with decreased lifespan, and parents are carriers for this autosomal recessive disorder, for example, CLN2 or Batten's disease, then having this information for their child and themselves can significantly, affect decision-making and what is available for them for future family planning. Psychologically, it can be extremely important for families to find closure. If they have a child who's significantly affected, a lot of families have personal blame, and being able to tell them that this is nothing that they did or nothing that could have been prevented. This is an underlying genetic etiology, often provides closure. And this is very important for families. It also ends sometimes their year-long or even decade-long diagnostic odyssey. And then it also provides support organization access, which is very helpful for a lot of families. It also helps them connect with other individuals who have the same underlying genetic diagnosis. Sometimes what happens is if we identify a patient who has an underlying genetic diagnosis, it also leads to cascade testing of other family members, especially if this genetic diagnosis has implications for future clinical management. So to summarize, genetic testing has both clinical utility and personal utility, and is therefore very important. Now, the top row with the bullet points shows the traditional, clinical utility, or what we do when we evaluate a patient with, epilepsy. But what we see is that, initially a patient comes in, gets evaluated. There's a clinical assessment by a neurologist, usually in the case of epilepsy. They're provided a clinical diagnosis based on the symptoms and based on the history of the patient. And then they're generally provided generalized treatment that we know should work for the clinical diagnosis. Now, in today's day and age, and with the advancement of genetic testing, this algorithm for patient evaluation changes a little bit. So the patient will still receive the clinical assessment, but depending on the comfort level of the provider that they see, sometimes genetic testing is ordered and sometimes genetic testing is not ordered right away. But if genetic testing is ordered kind of at the first or second visit, you very quickly receive potentially a molecular or genetic diagnosis, and that can affect and lead to personal treatment rather than generalized treatment. So putting us in the realm of precision medicine. Now, precision medicine is defined by the National Research Council as the ability to classify individuals into subpopulations that differ in their disease susceptibility, biology, and or prognosis, or in their response to a specific treatment. Interventions can then be concentrated on those who will benefit, sparing expense and side effects for those who will not benefit from a specific treatment. So 2 examples listed for genes where genetic diagnosis leads to precision medicine are SCN1A and SCN2A. So SCN1A is the gene that is known to cause the Dravet syndrome, which is a pretty severe developmental and epileptic encephalopathy of early onset. It can also cause genetic epilepsy with febrile seizures and a different type of developmental and epileptic encephalopathy. Now, the reason that genetic testing for SCN1A is important because if you identify a variant that causes loss of function, there is FDA-approved treatments specifically for patients who are diagnosed with certain genetic epilepsies, such as Dravet syndrome in the case of SCN1A. And it'll also allow us to determine if there's other medications that we should probably avoid. In the case of SCN1A loss of function variants, we would avoid sodium channel blockers. SCN2A is another sodium channel, and that's involved in benign familial neonatal epilepsy. It can cause genetic epilepsy with febrile seizures, but it can also cause some severe developmental and epileptic encephalopathies, such as Odahara syndrome. The importance for SCN1A is determining if the variant that the patient carries is a gain of function variant or a loss of function variant. If you have a gain of function variant of a sodium channel, you want to block the sodium channel. If you already have a loss of function, blocking that sodium channel could exacerbate the symptoms and potentially worsen the seizures. So this is where a molecular etiology is very, very important, and having a specific genetic diagnosis and genetic variant can play a significant role in clinical management. Now, this table shows several examples of how a genetic diagnosis can tailor a patient's management. So certain types of genetic changes are amenable to certain medications and others are not. So we previously in the prior slide talked about SCN1A and SCN2A, but there's also KCNQ2 where certain medications can be more helpful. Now, for pyridoxine-dependent epilepsy, which is caused by the ALDH7A1 gene, the treatment is supplementation with pyridoxine, right? So you're not giving a prescribed medication to treat generalized seizures. You're giving a supplement and therefore treating the underlying diagnosis or the underlying etiology for the symptom. And those patients are very responsive to pyridoxine. Now, we already talked about SCN2A as the cause of Dravet syndrome, where we would avoid certain types of medications. Now, certain genetic etiologies are amenable to dietary changes. So, GLUT1 deficiency caused by the SCL2A1 gene is amenable to the ketogenic diet. And that is the mainstay of treatment. The patients tend to do really well the sooner they're started on the ketogenic diet. Sometimes they don't need any seizure medications. Now, having a molecular etiology can sometimes lead to enzyme replacement therapy in the case of CLN2 or Batten's disease, which is caused by pathogenic variants in TPP1. It can also lead to initiation of palliative care, for example, in variants that cause Alpert-Huttenlocher syndrome, which is caused by POLG, which is a degenerative disease with early lethality. Surgery can sometimes be considered in patients that have been diagnosed with TSC1 or TSC2 that causes tuberous sclerosis. And then there's certain genetic changes or genes that, the symptoms can really be changed or improved by avoidance of certain triggers. So PCDH19 associated epilepsy, if you're able to control body temperature, it can make a significant difference in seizure frequency and seizure severity. Now, with all this data and all this, information that I've provided so far, I think, hopefully you understand why genetic testing is so important, both on the clinical utility side, but also on the personal utility side. Now, clinically and research-wise, genetic testing is really, really important to advance our knowledge of currently available treatments and move towards advancing our treatments and hopefully leading towards the development of cures for some of these genetic disorders. So gene discovery is possible because of the next generation sequencing era, right? And gene discovery not only gives you the ability to provide a diagnosis, but if you have a cohort of patients who have a specific genetic etiology, you can collect, depending on the frequency of this genetic etiology, sometimes hundreds of patients and perform natural history studies. And natural history studies are very informative when we go to preclinical drug discovery and ultimately clinical trial design, right? All of this with the goal in mind of providing precision medicine for our patients and advancing our knowledge of treatments and cures for these disorders. Now, I want to talk about a case study of a patient that I saw and I'm currently involved in. And this is a little boy who came to me a couple of years ago. He was developmentally appropriate. Parents had no concerns, except that he had a first-time unprovoked seizure, right? So all of a sudden, the patient had a seizure and there was no trigger for a seizure. It wasn't a febrile seizure. It wasn't trauma-related. It was unprovoked. The pediatrician was very knowledgeable and had ordered an EEG or an electroencephalogram prior to the visit. So when the patient came to me, we were able to diagnose him with epilepsy because he had a first-time unprovoked seizure and an abnormal EEG that increases his recurrence risk of further seizures. So he received a diagnosis of epilepsy, but at the same time, we also started seizure medications to try to prevent the seizures. It was a long visit for the family, but I also talk about genetic testing for unprovoked seizures in young children. So the patient received genetic testing, and a couple of weeks later, we received the diagnosis of CLN2 or Batten's disease. And if you remember from the previous slides, Batten's disease or CLN2 is amenable to enzyme replacement therapy, Brineura. So this patient very quickly within the first 2 months after initial seizure onset was able to start enzyme replacement therapy, continues to receive enzyme replacement therapy every 2 weeks via a port that goes directly into the spinal fluid. And currently, his seizures are very well controlled and his developmental regression has slowed, all because he received a genetic diagnosis soon after presentation. Now, with all of this data, it's not surprising that guidelines have been shifting over to the recommendations of genetic testing tiers over the past couple of years. So I want to highlight the guideline from the National Society of Genetic Counselors, which was published in 2022 and is endorsed by the American Epilepsy Society. And this guideline recommends that exome or genome testing is considered as a first-line test for individuals with unexplained epilepsy, regardless of age. I want to highlight the regardless of age because it's becoming much and much more common to also offer adult patients genetic testing for their unexplained epilepsy, right? So we should consider exome or genome sequencing as a first-line test for patients with unexplained epilepsy. And the American College of Medical Genetics and Genomics also recommends exome or genome testing as a first-line test for pediatric patients with developmental delay or intellectual disability. So I want to talk a little bit about exome and genome sequencing for patients with epilepsy. So, when we talk about next generation sequencing, genome sequencing analyzes the entirety of an individual's DNA, which is known as the genome. The genome includes approximately 20,000 genes. Exome sequencing analyzes the protein coding regions of those 20,000 genes that are in an individual's genome, and that is known as the exome. The exome is thought to contain most disease-causing genetic variants, most of them, not all of them, right? The way that exome sequencing is done is that a patient sample will be obtained, DNA will be isolated, the DNA will be fragmented into libraries. The fragments will be amplified, they will be sequenced, and then there are algorithms that help filter down the variants, and there's a significant component of data analysis that occurs with exome and genome sequencing. So just to summarize the different types of genetic testing that we can order clinically, our genome, which again analyzes all the exons and introns, which are the intervening sequences of an individual's genes, right? This is a broad approach that can include newly discovered or rare genetic causes. Exome analyzes all the exons in an individual's genetic information, and then it's a broad approach that includes newly discovered or rare genetic causes. A multi-gene panel tests for the most commonly associated genes with a certain condition, such as epilepsy, and size of the panels can range from very few genes to several hundred genes. A chromosomal microarray looks for extra or missing pieces of chromosomes called copy number variants. The size of copy number variants can range from one gene to multiple genes. And then single gene sequencing tests a single gene when there is high suspicion or family history of a specific genetic disorder. So the utility or the diagnostic yield of these different genetic testing strategies are as follows. So genome, depending on the situation, can provide a genetic etiology up to 48% of the time. Exome, right now, it's currently accepted that it provides, a positive diagnosis about 25 to 24% of the time, but this varies depending on the studies that you look at and depending on the conditions that were studied. Now, a multi-gene panel up to 19% of the time, a chromosomal microarray less than 10% of the time, and the single gene does not have very high utility unless there's very strong clinical suspicion or an underlying family history, right? So just to circle back with all this information, just going back to the recommendations of exome or genome sequencing as a first-line test for individuals with unexplained epilepsy, regardless of age. So kind of the algorithm that is recommended by the National Society of Genetic Counselors that was published in 2022 is as follows. And the first step, or kind of the split point here, is, does the patient have an epilepsy phenotype associated with a single gene or gene class, right? If the patient has a clear-cut, symptom that makes you think, yes, this can only be one gene, or there's an affected family member with the same symptoms, then we move towards targeted sequencing. Here on the right? And then if it's positive, you get a diagnosis. If it's negative, then it goes back to looking at other genetic testing strategies. But if the patient presents with just seizures in general, there's no family history, there's no specific etiology that the clinical team thinks could be the potential etiology, then you have the option of either going straight to exome or genome sequencing or multi-gene panels, right, which are a little bit more limited. If we look at exome or genome sequencing, if we go first line for exome or genome sequencing, we take a look at all of the coding regions of our genome, and if that is positive, you get a diagnosis. If that is negative, then often there will be copy number variant analysis that is performed. But I will highlight here that certain labs that offer exome sequencing already include the copy number variant analysis in their initial report. So you're kind of bypassing this step, right? So the recommendation would be to consider exome or genome sequencing as a first tier genetic test for patients with unexplained epilepsy, because it can significantly shorten the disease, discovery or odyssey for the family, and can save a lot of time and can save a lot of money rather than cascade testing. Now, genetic diagnosis enables better patient outcomes. Across 24 studies, up to 80% of patients with a genetic diagnosis had changes in medical management. This includes avoiding, stopping, or initiating specific anti-seizure medications, starting a ketogenic diet, kind of circling back to the slides that I discussed earlier in this presentation. Now, the conclusions here are that exome or genome sequencing is recommended as a first-tier test for all individuals with unexplained epilepsy, regardless of age or presence of comorbidities, highlighting that if you are very suspicious of just a single gene, that would not apply potentially. And this recommendation is based on evidence for genomic sequencing to impact treatment, management, and prognosis, and to inform recurrence risks. It is also based on comparative diagnostic yields, and this recommendation mirrors recommendations for other neurodevelopmental disorders such as intellectual disability and developmental delay, as highlighted by the American College of Medical Genetics and Genomics. The significance is that a genetic diagnosis enables the opportunity for better treatment, including up to 90% seizure reduction in some cases, and ordering comprehensive genetic testing, such as exome sequencing as a first-tier test, can impact medical management, improve patient outcomes, and significantly decrease the cost. Now, sometimes, not sometimes, but often actually, exomes are able to find genetic answers that panels cannot. And This is a manuscript that is in preparation, but this is a cohort of 22,600 individuals that have a clinical history of seizures or suspected seizures, and these were tested by GeneDx between 2019 and 2022. And what they find is that 75% of patients were reported to have genetic testing prior to exome sequencing. And that suggests that previous tests did not resolve all clinical questions and or identify a genetic diagnosis. 24% of these patients, some of which have already had genetic testing, received a genetic diagnosis through exome sequencing. Of the seizure-related genes with diagnostic findings, 57% of the genes that were identified are not present on currently available multi-gene panels for epilepsy. Such genes include CSNK2B, SON, SETD1B, etc. Right? And exome increases the potential to identify disease-specific treatments. 36% of patients with a diagnostic result through exome sequencing had variants, again, not available on many commercially epilepsy panels. 7.7% of patients with a previous non-diagnostic panel received a genetic diagnosis via exome sequencing that has specific treatment available, such as mTOR, DNM1L. And these 59 patients, when you quantify specific patient numbers, and their families would not have received a diagnosis and subsequent personalized treatment had their provider stopped looking for answers after ordering a panel. Therefore, exome sequencing decreases time to diagnosis when ordered as a first-line test and can be more informative and find more answers. The other important thing to consider when ordering exome sequencing is that exome sequencing allows for the ability to reanalyze the information that is available, right? It allows reanalysis, review of all the variants in an exome, reported and unreported variants, because the data is available, right? And we typically recommend exome reanalysis 18 to 24 months after the initial test was done, or if there's a significant change in the clinical information available for the patient. When we order an exome reanalysis, which does not require the patient or the family to submit additional samples, we find new insights in about 29% of cases, right? When we do an exome reanalysis, looking at this pie chart here, 8% of the time there's a positive diagnosis that comes back after exome reanalysis, a possible diagnosis 13% of the time, or a candidate gene or a candidate diagnosis also 8% of the time, right? So this is why it's so important to consider exome as first-line genetic testing, because also it's able to provide significant, information with regards to if a test is not available or negative today. It doesn't mean that it's going to stay negative indefinitely. Again, 29% of the time, there is other information that is available if you consider a reanalysis of the exome. So with this, I want to kind of talk a little bit about a case study of a patient that I saw in the clinic. This was a newborn male who was diagnosed with global developmental delay, delayed myelination, dysgenesis of the corpus callosum, epilepsy, and hypotonia. The patient had significant genetic testing, including a chromosomal microarray, chromosome 15 methylation testing, and an exome sequencing, all in 2019 that were non-diagnostic. When the patient established with me, we decided to perform an exome reanalysis, and the exome reanalysis was done, and actually in 2021, not 2019, and it showed that there was a de novo pathogenic variant in OTU-D5. And OTU-D5, as this snippet of this manuscript highlights, was identified only in 2021. So the genetic testing reanalysis was ordered in a timely manner in the year where this paper came out describing this gene as causing human disease. In 2019, we didn't know about this gene and the testing was negative. So that is why it's so important to consider exome reanalysis as our information and our knowledge about genetic testing grows. So implementation of genetic testing into clinical practice. So considerations, and I want to leave the audience with these thoughts here is, how do you implement genetic testing into clinical practice, right? And some of the factors that the groups need to consider are testing workflow, identifying the right patients, performing informed consent, maybe teaming up with genetic counselors, choosing a lab where they would like to order testing from. What is the pipeline when results come back, both negative, both positive results, variants of uncertain significance? And then is there a role for potentially a multidisciplinary clinic? These are the references that I use throughout my talk. And now I want to hand it over to Kristen.
Thank you so much, Dr. Herman, for that wonderful presentation. I just wanted to spend a few minutes here at the end to go over a recent program that was launched here at GeneDx to help patients access this testing. So as Dr. Herman stated, there are practice guidelines in place that recommend exome testing for patients with unexplained epilepsy, but we know that there are still some commercial payers who are not covering this testing or who have much stricter guidelines than the practice guidelines that are in place. And here in GeneDx, we never want insurance or out-of-pocket costs to be a real barrier for patients to get access to this testing. So in order to make this testing more equitable and to increase access to all patients and families, we recently launched our Epilepsy Partnership Program. So this is in partnership with our biopharma partner, like I said, to help increase access to exome testing for patients with epilepsy through this program. So there are some clinical criteria that a patient has to meet in order to participate in this program. One is they need to reside in the US, they need to be under 18 years of age, and they have to have experienced their first unprovoked seizure before 8 years old. So they don't have to be under 8 at the time of testing, but they just have to have had their first unprovoked seizure before that time. Another criteria is they can't have a previous diagnosis of a neurodevelopmental disorder, meaning they can't have had previous genetic testing that identified a pathogenic or likely pathogenic variant in a gene associated with a neurodevelopmental disorder. Also, the testing has to be ordered by an authorized ordering provider who is allowed to order genetic testing. And finally, the patient and their family consents to the data sharing practices. So how the program works is that this testing, the exome testing, could potentially be, the cost of testing could be covered by our partnership program. Now, one important question is what type of information is shared if a patient or family participates in this program? Some things that can be shared are de-identified health history, de-identified genetic information, and potentially contact information for the ordering provider. Some things that are never shared with our partner is personally identifiable patient information or the raw sequencing data from the exome testing. So any patient information that's shared is always de-identified, and the patients themselves will never be directly contacted by our biopharma partner. So let's look at a practical example of how this partnership program would work. So this is Claire. So she's a 6-month-old presenting with developmental delay and seizures. She initially began experiencing seizures at the age of 5 months, and her parents also noted a developmental delay over time. So she was referred to a local pediatric neurologist. Now, Claire's pediatric neurologist determines that exome is the most appropriate test for her based off her clinical presentation. And we confirm that Claire meets the criteria that I went over previously for our epilepsy partnership program. And so when they place the order through GeneDx for exome sequencing, they input the ESEPL partnership program code into the test order. And then the next step that happens is we will attempt to get testing approval through Claire's commercial payer, who is Aetna in this situation. But let's say Aetna denies the exome sequencing testing. At that point, the epilepsy partnership program would kick in and cover the cost of that testing for Claire. Whereas before, potentially the testing could have gotten canceled or the parents might have had to pay out of pocket for the testing. So in this situation, the partnership program kicks in, covers the cost of that testing, and makes sure that there's no financial barrier for this patient or family. And then ultimately, just as she would have before, they receive the clinical report. And Claire's de-identified patient information is shared with our biopharma partner. That's all I have to discuss on our epilepsy partnership program, and I will kick things back off to Kiara.
As a reminder to our webinar participants, if you have a question, please type it into the Q&A box in the control panel. We'd also like to ask attendees to take a moment after the webinar has ended to take our exit survey to give us your feedback. And we'll now start with the Q&A portion of the webinar. The first question is, what is the yield for a clinically significant result through whole exome sequencing for findings that would not be identified through a comprehensive epilepsy panel?
So this goes back to some of the data that I discussed earlier. So comprehensive epilepsy panels check for, a couple of hundred different genes, up to 300 or so different genes. And we know that genetic epilepsies can be much more heterogeneous than that. I mentioned earlier that as of today, we've identified over 1,000 different genes that can be involved in epilepsy. So epilepsy panels are good if you have a specific diagnosis in mind. But if the epilepsy panel is non-diagnostic, then definitely go with exome sequencing. But I'm a proponent of, unless there's clinical suspicion for something very specific, kind of do more broad genetic testing via an exome sequencing approach, right? And the data has shown that up to 80% of the time, no matter what the finding is, there is some sort of outcome from the broad genetic testing. So it has pretty significant both clinical and personal utility to find a genetic testing answer. But the limitation of epilepsy panels, or any kind of panel, is that the speed of additional genes that are on that panel does not keep up with our current advancing knowledge of gene discovery.
So the question is, what is the right approach to take when someone gets a VUS after whole exome sequencing?
Yeah, that is an excellent question. So, the interpretation of exome results is, it's a phenotype-driven approach. So the report will give you back a variant that is suspicious, possibly, for the symptom that the genetic testing was ordered for initially. So my approach is to look more closely at the variant, look more closely at the gene that is reported, and see if the gene is a clinical fit for the patient, right? So exome sequencing is great and it's informative, but if you don't get a clear-cut positive result, it's a little bit more homework for the clinician who first ordered the testing. And then it depends on the comfort level of the ordering clinician with regards to Do they think they need to see a geneticist to make that determination, or are they comfortable, looking a little bit more closely into the findings? But anytime I get a variant of uncertain significance, I take a deeper look and see if this could be a clinical fit, what is known about this gene, what exactly is the genetic variant? Is this a strong variant? Is this in a, an active area where we know that variants in this region of the protein are considered pathogenic, and then go from there. Now, other good approaches with this would be too, if this is a rare gene, right? Like reach out to the lab that has published a paper describing this gene and other researchers that may be studying this gene. And sometimes, functional studies can be done on the variant as well, right? But a variant of uncertain significance comes back less often on exome sequencing than on panel testing. But if it comes back on exome sequencing, I think you got to take a closer look and maybe get a little bit more information. And if you're not comfortable doing that yourself, look for people who can kind of do that work a little bit for the patient. Lastly, for that too, ultimately, if you do an exome reanalysis in 18, 24 months later on, most of these variants of uncertain significance will eventually be reclassified as either benign or pathogenic or likely pathogenic. So a variant of uncertain significance will not stay that way indefinitely.
Mm-hmm. And can you clarify the difference in diagnostic yields between exome and your triome epilepsy panel for patients who have isolated non-intractable epilepsy without any comorbidities?
So it depends on the patient population, but generally what the data has shown that we presented is 19% of the time, you will receive some sort of, genetic diagnosis from epilepsy panel. And then 24 to 25% of the time, you get a positive diagnosis from exome sequencing. But when you look at the data from exome sequencing, a lot of the time, these patients have had additional genetic testing, such as an epilepsy panel, such as, chromosomal microarray, et cetera, before they go to exome sequencing, right? So an exome decreases the time to diagnosis, and it's a very broad approach. I do think there is a role of epilepsy panels in certain situations, right? And again, ultimately, it's up to the clinician to make that determination, taking the full picture of the patient's presentation, family history, et cetera, into account.
And Kirsten, I think this question is for you about the program eligibility. The child must live in the U.S., but they don't need to be a U.S. citizen. Someone was asking for a clarification on that point.
Yeah, we don't check citizenship or anything like that. So just that they reside in the U.S. Part of the reason is that sometimes there's difficulty of getting samples received from anywhere outside of the U.S. Mm-hmm. Trying to get samples back and forth to our lab that resides in the U.S. So nothing around citizenship, just really where they reside.
Gotcha. Thank you. And that looks like all the time we have for today. Thank you for being so patient with my technical difficulties there. I'd also like to thank our speakers, Dr. Isabella Herman and Kirsten Kelly, and our sponsor, GeneDx. If you didn't have time to get to your question, and there were a lot of them, so I know we didn't, we'll try to follow up with our experts. And as a reminder, please look out for the survey after you log out to provide us with your feedback. And if you missed any part of this webinar or you want to listen to it again, an archived version will be emailed to all attendees. Thank you for joining us for this Genome webinar.